My name is Alan Schroeder. I'm one of the co-chairs along with Dr. Matthew of this COVID in Children seminar series, and we're excited to kick off 2021 with what should be a series of really interesting talks. Notwithstanding today's, we also have on January 14th, our first session really devoted to MISC, and we're going to invoke a case-based approach to discuss this vexing condition with subspecialists representing really a great multidisciplinary group. And then on January 21st, we are going to have what will be our third organ-specific session, the first having been on COVID in the heart, and then today's COVID in the brain and nervous system. And then on January 21st, we're going to lump a couple of sessions into one. We'll talk about some of the dermatologic manifestations. We'll talk about anosmia and dysgeusia in terms of some of the ENT manifestations. And then we're going to talk about eyes from the context, not so much of COVID impact on the eyes, but the pandemic impact on the eyes and what it's meant for all of the screen time for kids. And we have a great representative from ophthalmology to talk about that. So, but as we often do for these sessions, we're going to start with a trainee presentation, a so-called evidence quick hit. And today, really thrilled to have one of our excellent pediatric junior residents, Dr. Jen Sedler, who is going to present on one of the more concerning recent findings having to do with the UK variant of COVID. Dr. Sedler, as I already mentioned, is a second-year resident. She will be one of our chief residents, which is great, and is, I think, right now choosing between PICU and cardiology. So hoping to get her to see the light on that obvious decision soon. But Dr. Sedler, take it away.
Wonderful. Thank you so much. Going to share my screen here. Okay, so I know we have a lot of really interesting topics and discussions today, so I'm just going to keep this very brief. I wanted to present on the preliminary genomic characterization of this new lineage of the COVID virus that we've been seeing in the UK, and kind of describe this novel set of mutations that we are seeing occur. So as I'm sure you've heard of in the news, this is a distinct phylogenetic cluster named lineage B117, and that was detected within the COVID-19 Genomics Consortium UK dataset. And this accounts for an increasing proportion of the cases, not only in parts of England, but continues to grow in number, and then in regions where this is being found as well. So this is the phylogenetic tree of B117 and its lineage nearest outgroup sequences as of November, the end of November of 2020. So most branches in the global phylogenetic tree of COVID show no more than a few mutations and mutate at a relatively consistent rate over time. And that rate is usually about 1 to 2 mutations per month. However, this lineage has accrued 14 lineage-specific amino acid replacements prior to its detection, which is the most that we have seen since the COVID-19 pandemic. And so this right here, this was a regression of root-to-tip genetic distances between sampling dates, against sampling dates for sequences belonging to this lineage that you see here in blue, and those in its immediate outgroup in the global phylogenetic tree, which you can see there in brown. So what we're seeing is that the rate of molecular evolution within lineage B117 is similar to that of other lineages, but it is more divergent from the phylogenetic root of the pandemic, indicating a higher rate of molecular evolution on the phylogenetic branch immediately ancestral to B117. The nucleotide changes that we're seeing on this branch are predominantly amino acid altering, which is suggestive of a process involving adaptive molecular evolution, but it's not completely certain. So that leads us with the question, the natural question, which is, how did this happen? What evolutionary processes or selective pressures are giving rise to this new lineage? And the hypothesis that these authors present is essentially that it is chronically infected individuals. We know that immunocompromised hosts allow for a higher mutation rate, and they can often carry the virus for 2 to 4 months longer than other immunocompetent hosts. And that's high patient viral loads are treated with convalescent plasma, and studies have shown that virus genetic diversity increased after plasma treatment was given. So this setting changes the evolutionary dynamics in a few ways that they mention. The three ways that they talk about is the selection from natural immune responses in immune deficient or immune suppressed patients is weak or absent. The second way is that selection arising from antibody therapy may be strong due to high antibody concentrations. And the third and the last is that if antibody therapy is administered many weeks after many weeks of chronic infection, the virus population may be unusually large and more genetically diverse at that time. That masked antibody-mediated selective pressure is applied, and that creates a more suitable circumstance and environment for rapid fixation of multiple virus genetic changes through direct selection and through genetic hitchhiking. So then, of course, the question after that is, what is the biologic significance of these mutations? Of these 14, and of 3 of those 14 mutations, we have been pretty well described to various extents. And so those 3 include the mutation N501Y is one of the 6 key contact residues within the receptor binding domain. And so that's identified as increasing the binding affinity to ACE2. The second is this spike deletion that's been described in the context of evasion of a human immune response. And that's also occurred a number of times in association with other receptor binding domain changes. And then another one of the ones that's been previously described is this mutation P681H that's immediately adjacent to the furin cleavage site, which is also a known location of biological significance. So we know a little bit about what this may mean on a larger scale, given the experimentally predicted and likely phenotypic consequences. This is a mutation that we're going to have to continue to study more clearly in a clinical context and in laboratory as well. From what we know presently, what I was able to read is that we should be able to still use most testing systems in order to detect this strain. And we predict that the COVID vaccine will likely still provide adequate protection against this, but we still need some further studies in order to completely characterize the differences and changes that these mutations are going to form. And that's it.
Thank you so much, Dr. Sedler. Excellent presentation. Obviously, COVID continues to challenge us, and coming into 2021 does not mean that all problems are solved, unfortunately. But now moving on to our main part of the session, which is COVID and the nervous system. It is my pleasure to introduce Dr. Courtney Wusthoff. She is an associate professor of neurology at Stanford. She is also the director of the Neurocritical care at Lucile Packard Children's Hospital and the director of the LPCH Neuro NICU. And Dr. Wusthoff will take over as the moderator and introduce the panel of neurologists that we have. Please use the Q&A to put in any questions you have. Dr. Wusthoff.
Thanks very much. It's my pleasure to have a group of my colleagues with me today to talk about different ways that COVID might impact the nervous system. This is an area where there's been a lot of interest and attention, but still trying to gather reliable data. And because it's so multifaceted, I've asked a couple of folks to speak to their areas of expertise today. We're going to start out with Dr. Sarah Lee. Dr. Lee is a clinical assistant professor of neurology. She's also the director of the Pediatrics Stroke Program here at Lucile Packard Children's Hospital. And she's going to speak to us first about the role of COVID in pediatric stroke. This is something that's even recently gotten some media attention with a widely circulated story in the lay press about a small child who had stroke in the setting of COVID. So Dr. Lee, whenever you're ready, you can share your slides. And again, for the audience, if you can type in questions into the Q&A, we'll take some time at the very end to answer all of the questions. Dr. Lee. Great.
Hi, everyone. Thanks for having me. I'm going to talk about what we know and what we don't know about pediatric stroke and COVID. I have no financial disclosures. So as I think we've all heard in these sessions, SARS-CoV-2 is a virus that binds to ACE2 receptors that's expressed in multiple organs, including vascular, endothelial, neuronal, smooth muscle, pulmonary, cardiac, and renal tissues. And so it can have implications in all of those organs. There are laboratory studies of the COVID-infected transgenic mice that express these human ACE receptors, and some of them develop multi-organ lymphocytic inflammation, as well as a CNS type of vasculitis, which is relevant in humans as well. There's been post-mortem findings of inclusions within endothelial cells that suggest direct viral invasion. And then we're also seeing evidence of a post-infectious inflammatory response that's mediated by IgG antibodies. We know about COVID and stroke. So this got a lot of press early on in the pandemic. And I think we just need to take it with a bit of a grain of salt. It's hard to interpret some of these studies, particularly early on. The reported incidence as of now of stroke in COVID patients ranges from 1 to 6%. It's probably closer to the 1 to 2 range. Early reports, as you probably heard also in the lay press, observed, felt that there was a higher risk of severe and fatal ischemic stroke in young adults. There was a prior report that cited a sevenfold increased risk of stroke in COVID patients versus in influenza patients. We know that influenza also carries a risk for stroke. More recently, there's been reports of decreased occurrence of ischemic stroke globally. And this is probably multifactorial. There's a lot of confounding factors here. We definitely know that people were not coming to the hospital early on because they were scared of contracting COVID, and potentially patients with milder symptoms were staying at home. This may also be responsible for why some of the more severe stroke presentations have been noted in COVID patients. More recently in the adult literature, there's been some bigger registries, all retrospective, but they did not find an association between ischemic stroke and COVID. But I think multiple studies, and particularly one most recently in stroke in January of 2021, has reported that there are worse outcomes in stroke patients who have COVID versus those who do not have COVID. So higher in-hospital death, more severe symptoms, and again, we have to think about why these patients are presenting with stroke. Maybe there are patients with milder symptoms who are staying at home. We also know that co-infections in the setting of stroke can also worsen outcomes, as well as things that go along with those infections like fever and high glucose, et cetera. So what do we know about pediatric stroke? So just an overall background on pediatric stroke. The incidence is about 2 to 13 per 100,000 per year. About 50% is ischemic stroke. And I'll focus primarily on ischemic stroke for the talk today. Why do kids have stroke in general? So about 30% of pediatric stroke is a clot that comes from the heart. About 50 to 80% is thought to be due to a problem with the blood vessels, so either inflammation or irregularity of the blood vessels to the brain. And then about 10 to 30% may have some contribution from a hypercoagulable state. And we kind of see all of these three domains in COVID patients. About 30% is multifactorial or potentially cryptogenic. We can't identify a reason. It's well described that concurrent and preceding infection is associated with stroke in children. Children get, meningitis, they can get an infectious meningovasculitis along with that. And then a very well described entity in children, and particular to children and possibly in young adults, is sort of this post-infectious inflammatory condition, focal cerebral arteriopathy. This is a narrowing and irregularity of the blood vessels that presents with stroke, typically weeks or to sometimes months after an incident illness. Strokes have been reported in children with COVID-19. However, the existing literature we have is limited to very small case reports or case series that are retrospective, and I'll talk about a couple of those cases today. So how can COVID infection relate to stroke or cause stroke? So this is, I know, a busy diagram, but I like it because I think it speaks to the complexity of how COVID contributes to stroke risk. So I think, first of all, yes, COVID can directly invade the vascular endothelium, cause irregularity, blockage of the endothelium itself, and cause strokes by dissection, by microthrombi within the vessels. We know that COVID can indirectly invade the myocardium. It can contribute to cardiomyopathies and arrhythmias that can then lead to cardioembolic type strokes. It's been well described that COVID can trigger systemic processes that confer a hypercoagulable state, coagulopathies, and then a hyperimmune response with cytokine storm and hyperviscosity, which can lead to this, again, coagulable cascade. And then the other question is, are there other risk factors that exist even before COVID that COVID might then trigger? For example, and I sort of highlighted on the next slide, but sort of the potential for like dehydration in the setting of infection, anemia, hypotension, in the setting of a SIRS type response, does that precipitate stroke, for example, in a child who already has an underlying vasculopathy? So it's kind of does COVID cause a second hit that then manifests as stroke? And of course, we don't really know, well, some of these patients with COVID, would they have had stroke anyway, even if they didn't have COVID? And there may be a subset of that as well going on. So again, just in summary, there's direct viral invasion, there's infection-induced cardiac complications, coagulation factors, activation, hypercoagulable state. And then there's also the potential for SARS to impede the COVID-2 virus to impede the normal immune response and predispose folks to co-infections that are associated with increased stroke risk. And I'll talk about a couple of those cases in a bit. So probably the largest report we have of neurologic issues and COVID in children is an international report. There were 38 children with neurologic disease. They grouped these patients into 4 categories of illness. So they had the acute phase, they had an asymptomatic acute or subacute phase, they had the MISC patients, and then sort of an indeterminate phase. 7 out of 38 of those children experienced thromboembolic or vasculitic complications, and these occurred, I think importantly, in every phase of disease. So even when you're out of that acute phase, we know that children are prone to this post-infectious inflammatory condition, so that's something that we need to be vigilant over. So the most severe cases in this series were those children who had co-infection with other bugs. So 12 children had fulminant co-infections. 4 of those had very severe strokes, often leading to death. 2 of them developed M. tuberculosis that they had no prior exposure. They were not immunocompromised. And sort of the postulating theory is that there was breakdown of the blood-brain barrier and the choroid plexus, and that allowed or facilitated entry of tuberculosis into the CSF. Similarly, another child co-infected with MRSA and varicella zoster. So varicella zoster is a very common culprit named in pediatric stroke. We know that there's a post-varicella angiopathy that's been described, so potentially that was a contributing factor for that child. And then in a couple of other cases of meningitic and vasculitic multifocal cerebral infarctions, again, leading to death. So these are kind of the severe cases that we see. What about MISC and stroke? So, most children per report tend to have milder symptoms, but we know that there's a subset that experiences multisystem inflammatory syndrome. The median onset of MISC is, weeks after COVID symptom onset, and the neurologic symptoms that were reported in children were first reported in this population. So there's been several cases, I kind of tried to gather them up, of children who either presented with strokes and then developed criteria for MISC, or for example, MISC causing shock leading to arrhythmia, then leading to cardioembolic stroke. So you get this kind of cascading effect from all of these issues. It does seem that most strokes that occur with COVID in children are vasculopathic, so causing some irregularity of the blood vessels. Again, this is the most common reason that children have stroke in general. I'll reiterate this entity of focal cerebral arteriopathy. This is usually unilateral involvement of the intracranial anterior circulation in the absence of other systemic disease markers. And this should be expected to stabilize and resolve within 6 months, although children can have multiple strokes within that time period. There have been a lot of case reports of COVID-related arteriopathy, maybe not a lot, but probably a handful, I would say. And then there were also 2 cases very recently published, I think it's still in press in Pediatrics, of what they termed large vessel occlusion several weeks following an acute infection. So again, you're thinking this post-infectious inflammatory response, but they were kind of atypical for this classic FCA type picture in that they had elevated markers of systemic inflammation. One of the cases had bilateral strokes. One of them had multi-organ system dysfunction. You would not expect that with an FCA type picture, and neither fulfilled criteria fully for MISC given absence of fever. So I was just going to talk about a couple of the cases. One of them was an 8-year-old girl presented with right-sided weakness and speech difficulty. 3 weeks prior, she had had a febrile illness, but when she presented, her nasopharyngeal swab was negative for COVID, but she was IgG positive. So the presumption was that she had had COVID. at that time. She also had an anemia preceding this, which again can decrease oxygen carrying capacity. It can predispose to strokes. So again, are there multiple factors at play here? They actually felt that she had an embolic occlusion. They took her for thrombectomy, but then they found that actually the vessel changes looked more consistent with an arteriopathic process. So not really amenable to clot retrieval. And in fact, she re-occluded that left M1 and extended her stroke 5 hours after her thrombectomy procedure. There's a imaging modality called vessel wall imaging. This can sometimes help us see if there's inflammation or enhancement within the vessel wall. That's leads us more toward, okay, this is an inflammatory process. She did have enhancement on vessel wall imaging, and she did have elevated inflammatory markers. Second case was somewhat similar. This was a confirmed COVID positive case about a month prior, but again, negative nasopharyngeal swab on admission, but 7 days prior had this kind of stuttering course of stroke symptoms, and actually his imaging did not show enhancement of the vessel wall, so hard to know what to make of it. Another one, this was in the American Journal of Neuroradiology, a 12-year-old boy who was actually positive in the nasal swab as well as the CSF. This child had a lumbar puncture with imaging very classic for a focal cerebral arteriopathy. Negative CSF, kind of inflammatory markers, but some sort of mildly elevated serum markers. So how do we coalesce these cases and sort of draw conclusions? It's hard to know, but I think we can sort of assume that there's some inflammatory process that's contributing to stroke risk. Again, another similar case of a focal cerebral arteriopathy type picture, 2 months prior with fever, body aches, loss of smell. 1 month prior had tested positive for the antibodies, and then was again COVID PCR when she arrived. So each of these cases has some elements of preceding infection, of inflammation in either in the body or in the brain. And so this can probably contribute. We have a couple case reports out there of COVID as being a kind of an indirect contributor or like a second hit, as I mentioned. One of them was a 17-year-old who was found to have a patent frame in a valley. And then sort of the postulated theory was that maybe he was sedentary because he wasn't going out during the quarantine and developed a clot in his leg. He had negative lower extremity Dopplers. And then we actually had a case at Stanford of a 5-year-old kid, completely asymptomatic for COVID, came in with stroke and found to have moya disease, so non-inflammatory. We saw evidence of older strokes, so we know this was not something that occurred acutely. Incidentally found COVID positive. Was there something about COVID that maybe lowered his blood pressure a little bit or lowered his blood counts a little bit to predispose him to stroke at that moment? We don't know. Again, this is a 15-year-old girl actually who was pregnant who came in with a posterior reversible encephalopathy syndrome. Would she have developed PRES? We know PRES is associated with pregnancy. Would she have developed this outside of COVID? Again, we don't know the answer to that question. There's no way to have a crystal ball, but she did actually have very severe PRES and sustained some strokes as a result of that. So I'll just finish up by talking about a couple treatment considerations. What about intravenous TPA? We know this is the gold standard in adults within 4.5 hours of last known well. It is not FDA approved in children, but we do give it in certain circumstances. What do we need to worry about? There's no case reports of COVID positive children receiving IV TPA. There is an adult series of 13 patients who did get IV TPA. They did not have any hemorrhagic complications. Most inpatients improved clinically. These were by and large milder cases of COVID. So, you know, I think that we could still consider TPA if a child should present with it that window being COVID positive. Thrombectomy. So this is a longer time window, 24 hours from last known well. If a child were to present with a large vessel occlusion with COVID, what do we need to think about? So very recently, there was an adult series that looked at 93 adults with COVID and LVO. Again, their baseline characteristics were similar to non-COVID cohorts. They did, by and large, get successfully recanalized. This is on par with non-COVID thrombectomy numbers. However, they had much more severe courses. A 29% rate of 30-day mortality is very high. It's about 15% in all comers, or 10 to 15% in non-COVID, non-infected patients who undergo thrombectomy. And then they identified some markers that might be associated with poorer outcome. That one case report I discussed of a child with LVO who underwent thrombectomy that subsequently re-occluded. I think for children in particular, we always need to think really carefully if we see a large vessel occlusion, is there a thrombus sitting there that we can retrieve, or is this a vessel that's been narrow because of arteriopathy, in which case going in with a catheter and trying to pull a clot out is probably going to do more harm than good. So really carefully, evaluating the neuroimaging, evaluating the entire picture, and trying to figure out if a thrombectomy is warranted. What about antithrombotic therapy? Again, there's no great evidence of what the best course is. Anticoagulation or antiplatelet therapy for stroke prevention is the mainstay. In children without COVID or without adults, sometimes we do invoke steroids for a focal cerebral arteriopathy type vasculopathy. And we know steroids is a tenet of treatment for COVID. We know also there's an associated with elevated antiphospholipid antibodies. Whether this is a cross reactivity, it's not clear. It hasn't really shown that there's a clear correlation with thrombosis in these patients. And really the importance is, I think, key collaboration between multiple disciplines to kind of make these decisions. Thank you.
All right, thanks very much, Dr. Lee. So for the sake of time, people who have questions, please feel free to type them into the Q&A, and some of those we can answer during the talks, and if we have time at the end, I'll read some of them out loud for the recording. Meantime, our next speaker, it's my pleasure to introduce Dr. Jenna Klotz. Dr. Klotz is a clinical assistant professor of neurology and pediatrics. She's also the pediatric neuromuscular specialist and director of our pediatric neuromuscular lab. She's going to talk about another set of conditions that have also been featured in the lay press, neuromuscular complications of COVID-19, and give us a little bit of context for how we should be considering those. Dr. Klotz?
Okay. All right, so let's get started right away. Okay, here I have a couple disclosures. There are three main sites of neuromuscular complications in COVID-19. These are the cranial nerves, the muscles, and the nerves and nerve roots. Starting first with cranial neuropathies. So the best described one and the most common one is hyposmia or hypoagusia. This is felt to be mostly related to cranial neuropathy affecting the olfactory nerve or cranial nerve 1. It occurs in 50 to 60% of patients with COVID-19 and is not associated with disease severity. MRI of these patients with hyposmia shows evidence of olfactory bulb edema and enhancement. And on autopsy, there's evidence of severe axonal damage to the olfactory nerve. In contrast, other cranial neuropathies like those causing abnormal eye movements are more commonly associated with more severe respiratory symptoms. And while they can occur in association with encephalitis, Guillain-Barré, vasculitis, these also occur as isolated cranial neuropathies. On the right are two cases of two patients who presented with abnormal eye movements in the setting of COVID-19. And the imaging findings here with the red arrows are pointing at areas of edema and enhancement affecting cranial nerves controlling eye movements. What's the significance of anosmia and other cranial neuropathies in COVID-19? So for the most part, when viral infections cause hyposmia, it's because they infect the olfactory epithelial cells. And so it's usually reversible once the virus resolves. But for COVID-19, many patients have persistence of anosmia afterwards. And this suggests that there's particular neurotropism targeting the olfactory neurons rather than just the epithelium itself, and therefore increased neurovirulence. If you can access the neurons, that means you can backtrack into the olfactory bulb and brainstem and into the CNS. And since there are other cranial nerves that have terminals in the nasal cavity, like the trigeminal nerve, you can also backtrack through those nerves. Moving on to myalgias and myositis. Myalgias or muscle aches are quite common in COVID-19. In a couple large studies published from Europe of about 1,400, 1,500 patients each, the mean reported rate of myalgia was between 22 to 35%, but in some case series, they report frequencies higher, over 50%. It's more common in elderly versus pediatric patients, and it's one of the symptoms that persists past the end of viral shedding. There's a mild increase in CK in about a third of patients, and this might be a little bit more common in pediatrics. However, severe myositis, in which there's significant muscle breakdown and degradation, might be under-identified in COVID-19. One recent single center study of MRI spine obtained in patients with COVID-19 for various reasons identified paraspinal myositis in 7 out of 9 patients. This is depicted here on the right with the red arrows pointing at areas of an increased enhancement in the paraspinal muscles indicating myositis. Severe myositis, meaning painful weakness with high CK levels, is less common, but is an emerging entity in COVID-19. About 10% of patients with COVID-19 will have a CK greater than 10,000. And in general, with viral mediated myositis, it's not the virus directly infecting the muscle, but rather an immune response that gets generated in response to the virus that targets muscle fibers and leads to their necrosis. However, ACE2, which is the receptor for SARS-CoV-2, is reportedly expressed in skeletal muscle as well. And so this might be one of the first viruses to directly infect muscles causing myositis. That said, of the patients that have presented with the severe necrotizing autoimmune myositis in response to COVID-19, they seem to respond to IVIG and steroids, which is what's seen in classic post-viral myositis. On the right is a patient who had severe necrotizing myopathy affecting the lower limbs. And on her biopsy, there's this inflammatory infiltrate in the paramesial tissue, which is the connective tissue in between groups of muscle fibers. And that's something commonly seen in polymyositis or dermatomyositis. How do you distinguish between acute post-infectious inflammatory myopathy and muscle weakness or malaise associated with severe viral illnesses? Myopathic symptoms are common and multifactorial in severe systemic viral illnesses. But if you have a patient presenting with acute onset painful weakness, plus increased inflammatory markers, plus CK in the several thousands, you should be worried about a necrotizing autoimmune myositis. And this patient might also benefit from an immune modulatory therapy like IVIG. Moving on to Guillain-Barré syndrome. This is the most common cause of acute to subacute ascending paralysis, and it's caused by an immune-mediated polyradicular neuropathy, which means multiple nerves and nerve roots. The classic features are loss of deep tendon reflexes, high CSF protein in the absence of a high cell count, which is called albuminocytologic dissociation, and nerve root enhancement on MRI. The overall incidence is 1 to 3 per 100,000 people per year, and it occurs worldwide, affecting all ages. Males somewhat similarly to females, maybe slightly higher in males. For 2 out of 3 patients, there's a preceding mild respiratory or diarrheal illness. And it's thought that molecular mimicry might be one of the mechanisms that generates this immune response. Molecular mimicry describes certain bacteria and viruses that have proteins or lipids that share similar structures to those that make up the nerves. And so when the body generates an immune response, it inadvertently targets the nerves as well. However, GBS can also be preceded by surgery, trauma, or immunizations in some cases. Treatment is with IVIG or plasmapheresis. And GBS has several different variants, but generally is broken down into the categories of demyelinating or axonal. On the top picture here, if you think about a nerve as being like a wire, and you have the metal part of the nerve, which is the axon, or the metal part of the wire, which is the axon, and then the insulation around that nerve, that's called the myelin. So you can either attack the insulation, the myelin, or you can directly attack the axon or wire part of the nerve itself. One other variant worth noting is the Miller-Fisher syndrome, which is a triad of ophthalmoparesis, ataxia, and areflexia. For GBS associated with COVID-19, there's been about 45 patients reported in the literature so far. One review recently tried to look at these cases and was able to get sufficient data from 37 to make some comparisons in the group. The mean age of these patients was 59, with 90% being greater than 50 years old and 65% were male. And this was felt to reflect more the demographics of people who were hospitalized with COVID-19 early in the pandemic, rather than being a predisposition for elderly males. For these patients, SARS-CoV-2 was confirmed by PCR or antibody testing, and the CSF was negative for SARS-CoV-2, indicating that this wasn't a primary infectious cause, but rather more consistent with the typical autoimmune cause seen in GBS. 35 of 37 patients had systemic symptoms of COVID-19. 2 were asymptomatic, but had an exposure history and were found to have an abnormal pulmonary CT despite not having these symptoms. Most common symptoms at presentation were limb paresthesias, pain and weakness, and subtype that was most common was AIDP, similar to what's seen in general GBS cases. Patients were generally treated with IVIG or Plex, and despite that possibility of increased stroke risk, there weren't any thromboembolic complications in those patients. The majority showed improvement by 8 weeks, but there's limited long-term data available on them. How does COVID-19 associated GBS compare to non-COVID-19 GBS? Patients are more likely to have ongoing infectious symptoms at the onset of GBS, and that's felt to reflect the duration of COVID-19 symptoms in general. They're also more likely to have a faster onset of GBS in an earlier nadir. Most patients, the time to nadir, mean time to nadir was 5 days and range as early as 1.5 days, but none greater than 2 weeks. And more than a third required mechanical ventilation versus about 20% in non-COVID-19 GBS cases. This was felt to reflect the significant pulmonary disease associated with COVID-19 rather than something specifically related to COVID-19 GBS. In contrast with other pandemics like the Zika virus outbreak, so far there's no increased incidence of GBS with COVID-19. Lastly, since we did mention vaccines sometimes have this association with GBS, how worried should you be about this connection? Back in 1976, the flu shot was associated with an increased risk of GBS within 6 weeks following vaccination. In the end, that amounted to 1 additional case per 100,000 people vaccinated. ACIP guidelines suggest precaution with influenza vaccine if the patient has a history of GBS within 6 weeks of a flu shot, but it's not an absolute contraindication. And if the patient has other risk factors that would make them more likely to have significant mortality with the flu, then you should still consider vaccinating those patients. Since 1976, there's been a few reviews published looking at data on vaccinations and GBS risk with varying outcomes. They've either found there is no risk, there's no statistically significant difference, or there is a statistically significant difference, but very small. And overall, that amounts to 1 additional case per 1 million vaccinations. And so in particular, that increased risk of GBS following vaccinations seemed to be primarily associated with the version of the flu shot back in 1976 and hasn't really been proven or seen since. So the risk of GBS following vaccination if present is small and should not be considered a reason to decline vaccines that protect against serious illnesses. Here are my references, and that's all.
Great, thanks very much. So we've heard about 2 specific types of neurologic disease, about stroke and neuromuscular condition. Next, we're going to switch to Dr. Elizabeth Mayne to talk about more globally some of the more critical consequences of COVID infection that have been described. Dr. Mayne is a pediatric neurointensivist. Her research focuses on chronic inflammation and neurocognitive outcomes in animal models of pediatric stroke. And it's a pleasure to have her talk to us about a potpourri of topics next.
All right. Let's see. Can everybody see my slides okay? All right. So thank you so much for that introduction. I have no relevant financial disclosures. As you've heard, there's a very broad range of neurologic conditions that have been reported in association with COVID-19. Those range from things that are pretty benign, such as the headache or anosmia, all the way up to much more severe conditions such as stroke, intracranial hemorrhage, and ADEM. At this point, it's really not clear how often those complications are actually occurring. The incidence depends on which symptoms are considered to be neurologic. For instance, if you include that 40 to 50% of patients referenced by Dr. Klotz who have myalgias, obviously the rate of neurologic involvement with COVID-19 will be quite a bit higher. We are now starting to get a little bit of data from case series in children, although the quality of this evidence is quite variable and not all of the COVID case series report on neurologic involvement. In some of the case series that we do have, it seems like neurologic involvement occurs in about 5 to 10% perhaps of children with COVID-19. As you can see, there's an early cohort out of New York where they found 2 out of 22 children with neurologic involvement. And then in a cohort describing the Italian experience with their hospitalized pediatric patients, they saw neurologic involvement in 5 out of 168 children. We're also now starting to see some reports describing neurologic involvement in MISC. In most of these series, the rate of involvement of the nervous system is pretty low, around 6% in a New York cohort, and also replicated in a larger US cohort that was recently published. That incidence is comparable to a much smaller UK cohort from earlier this year. There was one series of a different set of cases out of New York that reported a neurologic involvement in up to 38% of patients, but they included a variety of much milder symptoms such as fatigue, headache, and muscle ache, which constituted the overwhelming majority of what they described as neurologic involvement. So we've been talking a little bit about the broad range of neurologic complications, but now I want to focus a little bit on the more severe end of that spectrum and talk about the sorts of things that we might expect to see in critically ill children. One of the things that's been most consistently reported in both the adult and pediatric literature we have so far is encephalopathy. It's quite common in adult cohorts ranging from about 15% to over 60 or even 80%, depending on which patient population you look at in adults. We're starting to see some descriptions of that in children as well, again, limited by which case series are actually reporting on neurologic complications. It seems like the rate of encephalopathy or altered mental status in children with COVID-19 infection ranges from about 10 to 20% on the higher end with children who require ICU admission, as we can see from this cohort in the UK, where they broke down floor cases versus those who required ICU admission and saw that about 20% of their ICU cases had encephalopathy or altered mental status. We're also now again starting to see some case series of MISC describing their experience, and the rate of encephalopathy or altered mental status seems relatively comparable there. 4 out of 27 cases, again, in that London cohort. That large US cohort of MISC cases I referenced on the previous slide did not describe altered mental status in particular, but notably 3 of the children in that series developed a rapidly progressive encephalopathy that devolved into coma within the first several days of hospitalization. The encephalopathy in both the children and the adults is really multifactorial, and it's not clear to what degree this is specifically from SARS-CoV-2 viral infection or involvement of the central nervous system versus more general critical illness or the inflammatory and immune response to the infection. We know that children who are critically ill and septic have a sepsis-associated encephalopathy. Multi-organ dysfunction in critically ill patients can produce things like uremia, which again will produce altered mental status. COVID also engenders a very brisk inflammatory response and this cytokine storm that's been relatively well described, which also produces encephalopathy. So there's this broad range of things that may produce the altered mental status, and the treatment depends on what the underlying etiology is, as does the prognosis. So if it's something reversible like a uremia, treatment of the underlying metabolic disorder should help improve the mental status. Whereas in adult cases where there's been more significant hypoxic types of injury, the encephalopathy does not improve as readily once the COVID-19 infection clears. Another thing that we're starting to see reported in some of the case series are seizures. This should be pretty unsurprising to all of us, since we know that both critical illness and respiratory viral infections are common triggers of seizures in both children and adults. A wide range of types of seizures have been reported in association with COVID-19 infection, generally on the order of, say, 3 to 10%, depending on which cohort you look at. You can see in these 2 New York cohorts, about 5 to 10%. In that larger Italian group of children, 5 out of 168 children had seizures, but notably 3 of those children already had a history of epilepsy or febrile seizures, so probably a predisposing or pre-existing risk factor. The UK has a nice large series that's been published recently where they found seizures in 36 out of 520 of the patients who required the children who required hospitalization for COVID-19. And they were, as we saw, able to break down into the ICU and the floor patients, and there was no difference in the rate of seizures based on disease severity. We have just the one case series so far for MISC that comments on seizures where they were seen in 3 out of 186 of those patients in the US cohort. It is worth noting that none of these series are following children prospectively for the development of seizures with screening continuous EEG, and we know that critically ill children are at risk for subclinical seizures, which may be not as readily detected. So it is possible that in the critically ill children, we are underestimating the seizure burden, but overall, it does not seem to be high. There are not any specific treatment indications for seizures that are associated with COVID-19 infection or with MISC. You would treat them based on the type of seizure, the child, and any other comorbidities. Encephalitis is something that comes up frequently in the literature, but is very broadly defined at this point. Most of the case series that report on encephalopathy define it as a combination of encephalitis, define it as a combination of altered mental status and some evidence of CNS inflammation, whether that's a pleocytosis in the CSF or evidence of enhancement on neuroimaging. We don't have very good epidemiologic data yet as to the rate or the incidence of encephalitis, but it overall seems to be pretty rare. It's been described both in COVID-19 active infection as well as in several of the MIS-C cases. Many of these patients have undergone CSF sampling to assess for direct active viral infection. And there have only been 2 or 3 case reports thus far where the SARS-CoV-2 virus has actually been detected by PCR in the CSF. The more common CSF profile is a mild pleocytosis and mildly elevated protein. So despite the fact that the virus may have a tropism for, say, the olfactory neurons, it doesn't seem that in the majority of these cases that we're calling encephalitis, that active viral infection is the etiology. Rather, it's more likely to be a para-infectious immune-mediated process. One of the conditions that sometimes gets lumped in with encephalitis in the case report so far, and sometimes is separated out by itself, is acute disseminated encephalomyelitis. This is another condition that's commonly triggered by viruses, and so it's unsurprising that we're starting to see case reports in both children and adults with COVID-19. As a reminder, this is a condition where you see acute onset of polyfocal neurologic deficits and encephalopathy. It is an immune-mediated demyelinating disease process, and you can see in the MR pictures here on the right, shows up as this high T2 or flare signal in the subcortical white matter. The severe end of the disease spectrum for ADEM includes this process known as acute hemorrhagic encephalomyelitis, in which the lesions are much more confluent, and there's also often hemorrhage. This has been reported in a small number of adults with COVID-19, but to date, not in any children with COVID-19. The treatment for acute disseminated encephalomyelitis is immunomodulatory therapy. There have also been a handful of kind of grab bag of a variety of other neurologic symptoms or injuries that have occurred in the context of COVID-19, but these are all very much on the level of individual case reports. And so we haven't discussed them as much here. So overall, I'd like to emphasize that the estimates for how often we're seeing neurologic complications in COVID-19 in children varies quite widely due to the rapidly evolving data that we're getting. It's really unclear which of these complications are attributable to the viral infection itself versus the immune response that it engenders versus overall systemic critical illness. Another thing to emphasize is that while we've reported things, or we've discussed things like ADEM, and we've discussed seizures, and we've discussed encephalopathy, it's really unclear if we're seeing these in excess of what we would expect to see with any other viral illness or viral pandemic. The good news is that overall serious neurologic complications seem to be relatively rare in children, with the caveat that greater disease severity seems to be associated with a higher risk of neurologic involvement in children as in adults. Thanks so much.
All right, thank you. So the recurring theme that we're hearing across all of these different topics is that happily neurologic complications, serious neurologic complications are rare with COVID infection, that they do exist, and we're still not seeing strong evidence that it's something COVID specific. It may just be a feature of the critical illness for the children who are described. For our last topic, last but not least, we're going to go to Dr. Laura Saucier. She is one of our senior pediatric neurology residents. She has a particular interest in neuroimmunology, and taking it a step further from it's always difficult to sort out what's a feature of critical illness versus what's just what's specific to COVID. She's going to talk about some of the more long-term features of COVID infection. Dr. Saucier?
Thank you, Dr. Wusthoff. I'll share my screen. All right, I hope everybody can see it. Good afternoon. Thank you for tuning into the webinar, and thank you, Dr. Wusthoff, for allowing me to participate. I'll be talking about some of the patient-reported neurocognitive features of long COVID. We felt that this was an important topic to present because it's one that's receiving increasing national attention and one about which we've begun to field questions from concerned patients and families. Of course, in pediatrics, the question we will most often encounter is if and how long COVID may affect children. And spoiler alert, unfortunately, the short answer to this question is that we simply don't know. We're at the very early stages of understanding the epidemiology and underlying cause or causes of the syndrome. And we just don't have enough evidence, and a great deal more study will be required before we reach any conclusions. So today I'll be highlighting what little we do know, but just as importantly, what we don't know, what gaps in our current understanding still remain. I have no financial disclosures. So many of you have probably seen some of these headlines. A lot of information out there about long COVID comes not from peer-reviewed publications, but rather from the lay press. Science just hasn't quite caught up to the efforts of patients, families, and the media to really get these stories out there and to bring awareness to the general public. And while most of the media highlight the experiences of adult patients, this October 22 article from the New York Times does report symptoms termed long COVID arising in a 12-year-old girl. She, along with other members of her family, were diagnosed with COVID in New York City in March. And she's since been experiencing fluctuating symptoms that include extreme fatigue, decreased exercise tolerance, lightheadedness, nausea, chest pain, dyspnea, and joint pain. It is important to note that she never tested positive for COVID, either by PCR or later by antibody testing, though there's of course a chance for false negatives for both of these tests. This is a screenshot that was taken directly from the CDC website. And as you can see, the patient-reported symptoms span multiple different organ systems and do include neurocognitive and neuropsychiatric features. Notable and commonly reported non-neurologic symptoms include things like cough, sore throat, chest pain, rash. As I mentioned previously, we still have many unanswered questions, and prominent among these is what may be causing or at least contributing to these symptoms. I suspect it's likely multifactorial, and I doubt there's a single underlying explanation for all these cases. There's some emerging data that the sequelae of acute COVID infection, particularly in more severe cases, can contribute to persistent symptoms. For example, a prospective study in JAMA Neurology reported that about over 75% of patients, only a third of whom actually required hospitalization, had evidence of ongoing cardiac involvement at a median of 3.5 months out from their diagnosis. Likewise, there have been some early studies showing lasting lung damage in patients with persistent dyspnea, fatigue, and other cardiorespiratory symptoms. There are many other proposed mechanisms, but really very little study. I think this is one of the most important areas for us as a scientific community to address in order to better provide our patients with some of the answers that they're seeking. So now I'll spend a little bit of time going through what we do know about the prevalence of persistent COVID symptoms from government studies and peer-reviewed publications. These include 3 fairly limited studies in adults, only one of which is prospective, and which are all very difficult to extrapolate to our pediatric population. And then there is 1 limited case series in children. So first, this is an Italian study. It was done earlier in the pandemic, showing that almost 90% of patients had persistent symptoms 2 months out from diagnosis, most commonly fatigue and dyspnea, but between a 4th and a 5th also had joint pain and or chest pain. There were other symptoms as well that was seen somewhat less commonly. The limitations of this study is, this is not a prospective study. There's a relatively short follow-up period, and it's difficult to extrapolate to our pediatric population, which is much younger. The average age in this study, 56. And also, thankfully, children are usually do not have the kind of severe cases. They have more mild or even asymptomatic cases, whereas the adults included in this study all were ill enough to require hospitalization, and most of them had COVID pneumonia. The second study to review, US study, 270 patients, again, all adults. About a third of them had persistent symptoms at a median of 16 days after diagnosis, most commonly being cough, followed by fatigue and dyspnea. Again, this is honestly more a study of short COVID than long COVID. The limitation is primarily the very short follow-up time. And again, it only included adults and was not prospective. One of the things I do want to note is that they broke down patients by age group and underlying conditions. And so some more good news for children is the persistent symptoms were more common in older patients and those with more underlying conditions, though it is true that a non-insignificant percent of the younger patients 18 to 34 and those without any underlying conditions did continue to report symptoms at 2 to 3 weeks. The last adult study that I'll be going over is a UK study out of King's College London, the COVID symptom study. It's ongoing. And this is adults who received outpatient COVID tests that were positive. 10% reported persistent symptoms at 1 month, and a much more rarely at 3 months, reported in 1.5 to 2% of patients. The great limitation here again is children were excluded. So lastly, the study in which children were not excluded, we have a case series, only 5 kids, ages 9 to 15. They had persistent and fluctuating symptoms for 6 to 8 months. They were not able to go back to school full time by 6 to 8 months, though some did improve somewhat. Symptoms described were those which have been reported in adults as well. Limitations, this was a case series. There were only 5 patients, and notably none of them actually had confirmed COVID infections. So none of them were positive by either PCR or by antibody testing. And of course, as we've mentioned, they did all receive a clinical diagnosis, and there's always the possibility that they had, that the tests without 100% sensitivity missed their COVID infection. And then associated systematic review found that of the 179 relevant publications that were interrogated, there was no data on pediatric long COVID, which really speaks to our gaps in understanding the prevalence among children. So next is a talk about COVID in the brain. So I'd be remiss if I didn't spend some time really highlighting the specific neurocognitive and neuropsychiatric features that have been reported among patients with long COVID. So here are some of the symptoms listed. One we often hear about is brain fog, typically difficulty with concentration, attention, memory, or learning. I thought this quote from Dr. Paul Gardner from the Liverpool School of Tropical Medicine was particularly, gave a vivid picture about his experience with long haul COVID. He says, "I'm unable to be out of bed for more than 3 hours at a stretch. My arms and legs permanently fizzing as if injected with Szechuan peppercorns. I have ringing in the ears, intermittent brain fog, palpitations, and dramatic mood swings." So one of the questions that's been emerging about potential neurologic involvement is whether some of the symptoms may be explained by autonomic system dysfunction. The national media has featured at least a few articles about patients diagnosed with POTS following COVID infection. Some of our own autonomic neurologists here at Stanford, Dr. Miglis and Dr. Girardi, recently published a case study about a young man who they diagnosed with POTS after a positive COVID test. And in addition, the possibility of autonomic dysfunction has been highlighted in a recent article in Neurology by Dr. Nath. The table on the right of the screen right now, it was taken from the article and highlights some of the patient-reported symptoms of long COVID that, among other explanations, could be attributed to autonomic dysfunction. Lastly, I want to end by highlighting the article I mentioned previously by Dr. Nath. It was published in Neurology at the end of September. It serves as more or less a call to action for neurologists to play a more active role in understanding the neurologic, neurocognitive, neuropsychiatric features of long COVID. So in conclusion, we are still in the very early stages of understanding long COVID. Thanks to strong patient advocacy and national media attention, there's increased awareness, but we still need prospective studies to better understand prevalence, risk factors, symptoms. We still need investigation into potential underlying mechanisms, and we need to address the needs of our patients with robust outpatient post-COVID clinical care and support. Here are my references. Thank you for your time.
Thank you. I think that's really reassuring for pediatricians and families to hear that even though we've seen a lot in the lay press about long haulers and brain fog, actually some of those case reports didn't confirm that there was COVID-19 in those patients, and it was more a clinical diagnosis. And reassuring to hear for all of these different consequences that the overall rates are roughly similar to what are seen in other viral conditions. so we don't necessarily have to fear that there's going to be a dire course for every mild COVID infection. I think we're out of time, but I'll just ask one question for the panelists, and anyone can jump in. Given the little data that we have, but seeing that there's not a huge difference in terms of complications after COVID and other viral infections, is there anything different that pediatricians should recommend to families in terms of signs to watch for, or should there be any different kind of follow-up for a child who has just a mild URI or an asymptomatic COVID infection?
I guess I would say for like, I don't think you have to universally watch for this, but if I were worried about someone who might be showing signs of Guillain-Barré, for kids, sometimes it's something like increased tripping or falling, increased clumsiness. They won't always describe numbness, but they might have back pain, or they might say there's like an itchy or prickly feeling in their legs or arms. That might be the way that they characterize numbness. And then if you were worried about something like just muscle aches versus myositis, I think a change in the color of the urine, so something looks more like Coca-Cola rather than just general muscle aches that you get in any viral illness.
Great, thanks very much. I think we're at time now, so there's some other questions in the Q&A box that maybe our panel can take a look at. Otherwise, thanks very much for joining us, and thank you for having us today.
Thank you to the team Neurology here at Stanford for such a comprehensive look at all the different manifestations. So we are very appreciative. Thank you to you all. Have a good day.
Thank you, guys. That was awesome.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.